All right, class, what I wanted to do for you was briefly give you a little video on a follow-up for both of these three cases, just giving you a little window into what I was looking for in each one of these cases, starting off with the hand case of our 70-year-old complaining of hand pain, Clarissa Cobblestone, who basically complained of paresthesias in the first three digits of both hands. So when you looked at the subjective findings of this particular case, from a neurological, physical medicine, musculoskeletal diagnosis standpoint, everything that the patient essentially presented with led towards carpal tunnel within the first three digits. And the fact that when we look at some systemic issues, the patient was fatigued, has a history of family history of Addison's disease, Hodgkin's disease. So again, the fact that there is a strong correlation with carpal tunnel and thyroid issues, and the fact that the patient has been fatigued as well, there's the possibility that primary hypothyroidism could be going on with this patient as well. As well as, could it be a resurgence or an issue with the Hodgkin's disease as well? So what I was looking for essentially was, when you went in the room with this patient, on visual inspection, you also had the image of thenar wasting, which we know indicates more advanced stages of the carpal tunnel issues, which were bilateral. I also asked you to perform some of these peripheral neuropathy tests like Tinel-Sign, Phelan's, as well as reverse Phelan's, which were all essentially positive in this patient. And the fact that the patient had numbness and tingling in both hands in the three digits, I was hoping that you could get to some neurological testing as well, since the patient complained of, paresthesias in both hands. So ideally they would have had delayed C6 brachioradialis reflex, reduced pinwheel sensation in the thumb, middle finger, and ring finger of the right and left hand, and weak wrist extension was noted as well. So essentially everything leading towards CTS for C6 and C7 and partially C8 dermatome levels, again leading to a diagnosis of CTS. When you look at some underlying causes of carpal tunnel syndrome, again, as I pointed out, various medical conditions including thyroid disease, diabetes, or arthritis can be some underlying causes of CTS as well. Also, we know pregnancy can be a variable here as well. Who gets it? Middle-aged to older adults, more likely to develop this. And again, from a diagnostic testing standpoint, the strongest evidence for CTS is going to be conducted using a nerve conduction test and followed up maybe by an EMG. From a clinical management standpoint, there's a variety of different clinical approaches here, from nonsteroidal drugs to steroids itself, cortisone injections, to surgical procedures, right? So when we look at the clinical guidelines from the American Academy of Orthopedic Surgeons, they ideally recommend non-operative treatments initially for patients with CTS, and then which can include myofascial release, which can include myofascial stretching, which can include manipulation or mobilization of the carpals, transverse friction massage of the flexor retinaculum. Also, as you can see here, local steroid injections or splinting could be a big option for our patient as well. A cock-up night splint. And then, of course, worst case scenario, we can recommend a carpal tunnel release for the treatment of CTS as well. When you look at some of our post-encounter questions for this, I was really hoping that you could put the pieces of the puzzle together, that could there be a strong correlation here with hypothyroid issues. So if that was the case, based on our choices here, loss of lateral eyebrow, cold intolerance, and coarse or sparse or dry hair were all associated with hypothyroidism. Ortho and neuro testing, again, upper limb tension test, dermatome testing, and Phelan's tests are some things that we would have wanted to do on this patient. When we look at some diagnoses, definitely CTS comes to mind, primary hypothyroidism comes to mind, recurrent Hodgkin's disease comes to mind. Also, I gave some partial points for cervical disc herniation. Could that be an issue here in giving you some symptomology that went into the hands? Could it be a lateral disc lesion or lateral canal? Patient is 70. Could they have lateral canal stenosis going on? Again, affecting both hands. So I was pretty flexible on this case. And then finally, of course, on inspection for this particular case, the patient had bullseye rash. And as we know with that bullseye rash, erythema migrans, right? Essentially strong association with Lyme disease. And the fact the patient had joint pain, again, fever, chills, muscular pain in the neck, extremities are common early signs of Lyme disease. Now, interesting, our patient, the current evidence states that an individual can, with suspected Lyme disease, up to the first 3 days, may not present with a fever, and our patient was not febrile by any means. However, they did have the classic bullseye lesion or rash. So again, I was hoping that you'd be able to detect that and pick that out with this particular case. So it was pretty straightforward, but again, we had some difficulty with answering some of the questions for this particular case. All right, our second case here was with Kenise Morehouse Grand, who was 45-year-old female complaining of left shoulder pain and stiffness. Again, when you look at the subjective complaints here and basically cluster or group these symptoms together, there's a strong, the patient's family history included diabetes. Patient had limited movement. Lying on their side aggravated it, and basically they had pain with a lot of movement, and there was stiffness in the shoulder as well. So again, for this particular case, what I was really looking for here was making the correlation or the association of possibly diabetes and frozen shoulder. And this patient essentially presented with frozen shoulder adhesive capsulitis, and the fact that, I think in the post-encounter, I gave you these subjective findings here, limited range of motion, positive empty can, positive liftoff. They had an elevated hemoglobin A1C, so even if you didn't, hopefully at this point you guys should at least understand what the blood test, and we've talked about that before, hemoglobin A1C is elevated, and the fact that you had deltoid atrophy occurring as well on inspection, disuse, patient favoring it, again, strong correlation with diabetes and adhesive capsulitis. So again, on inspection for the patient, of course I can't reproduce this, but that's why I gave it the results in the post-encounter, that the patient had wasting or shrinking of the deltoid muscle, supraspinatus test, liftoff sign, all of those patient was unable to perform. Neurological testing, sensory would have been intact for the most part, reflexes intact, again, for the most part. When you looked at your post-encounter questions here, really for this patient had a strong correlation of adhesive capsulitis, type 2 diabetes mellitus, disuse muscle atrophy is really what I was looking for. Cryo, and then based at the fact had adhesive capsulitis, there's strong evidence of cold laser, Codman's, and wall walking exercises. Out of the choices here, were probably had a stronger predictive value if you use those therapies for adhesive capsulitis. And ultimately, risk factors were diabetes, immobilization, and hypothyroidism. I gave some partial points for cervical myofascial pain syndrome. Notice there was a trend among many students picking this. So again, I can kind of buy it if you've got some issues going on in the cervicals. Could that be an underlying risk factor for this as well? It's a possibility. So again, to me, this case was pretty straightforward, but again, at the end of the day, I was asking you to perform a cluster of tests here: Hawkins-Kennedy test, infraspinatus muscle test, and shoulder arc test. So when I asked you to perform a cluster of tests, what I was really referencing here was this cluster from the CPR PowerPoint that I gave you. If we're suspecting impingement syndrome with the patient, you would perform these cluster of tests, which were all negative in our case. Full thickness rotator cuff tear. Again, they would have been negative in our case. With our particular patient, supraspinatus test would have been weak. Lift-Toss test was positive. Shoulder arc test, they wouldn't be able to bring that shoulder up. Again, indicating limited range of motion, leading towards a stronger predictive diagnosis of adhesive capsulitis or frozen shoulder. So essentially that's what I was looking for this second case. All right, for our final case was the case of the 37-year-old complaining of the worst headache. And, her tempo is slightly elevated, blood pressure was high. And as you read through the history here, you had a lot of red flags with this patient. And ultimately, hopefully, as you read through this, a couple of things came to mind. And probably the first of your clinical reasoning and your clinical approach probably should have been meningitis, and then several students picked out stroke as well as a possible option here. Now, the fact that it's been going on for about 30 hours and it's unbearable, right? So, we had a lot of significant red flags with this particular case, and I was hoping that, you would hopefully suspect that meningitis was your priority, and your priority was to rule that out immediately. And I was hoping that you'd, go in the room. I gave you the vitals already, and if you were suspecting meningitis, well, you had two options here. One, you didn't have to do anything and just told the patient that you wanted to refer them out immediately because of the symptoms that they were having. Or two, you could have probably performed one or two tests to confirm your suspicion of meningitis, and, Kernig sign, Brudzinski sign, any of these meningeal irritation signs or meningeal tests could be some good clinical indicators, from Kernig's to Brudzinski's. Several students did slump tests. I guess performing slump, you stretch the dura, irritating the dura, making the correlation that it's a possible meningeal irritation test. So that could also be an option. The other thing was, I asked, what imaging would you do? Well, interesting. Hopefully your primary would have been maybe referring the patient out for a lumbar puncture. I mean, realistically, when you look at diagnostic studies of acute bacterial meningitis, is not made on the basis of imaging studies. Rather, it's established in the patient's history, physical examination findings, and laboratory results. So again, lumbar puncture is the single most important diagnostic study. So if you had told me lumbar puncture, that's what I was looking for. But also, currently, MRI is the most sensitive imaging modality because the presence and extent of inflammatory changes in the meninges can be detected. So MRI is another good test or indicator that could be ordered as well. So I was looking for any one of those with your particular patient. And then essentially this was a medical emergency. One of the other key things here with meningitis is if you suspected it, did you wear the mask? Your protection is the first thing that I would always want to consider. And if you suspected a patient with meningitis, hopefully you want to protect yourself. And I know several students did put on a mask. So again, in the order of likelihood for differentials, meningitis, migraine headache, subarachnoid, Berry aneurysm, cocaine-induced intracranial hemorrhage, all of those were good possible options. In regards to a diagnostic workup, lumbar puncture, CBC, looking at the CSF, CT, MR, or